in top of the holy space of the cholangiocarcinoma, and I'm very happy to see Courage following last summer. So today I'm talking about the adjuvant chemotherapy after resection cholangiocarcinoma. I always talk about surgical technique or surgery, but today I'm talking about this topics, adjuvant chemotherapy, because I'm working as a surgeon in HBP surgical service, but our official name of our service is a surgical oncology unit. So division, please look at carefully in our paper, division of surgical oncology is our official name. So we focus on resection surgery and diagnostic imaging and interventional radiology, except for the endoscopic approach and anatomic pathology and chemotherapy. We by own perform the chemotherapy systemic and in the systemic and adjuvant setting. So today, I'm talking about the current survival probability, the current status after surgery. And second is the adjuvant chemotherapy. And third is a promising preoperative chemotherapy. Sometimes we use in the chemotherapy in the adjuvant setting. So we're talking about these three major topics. And I introduce the same when I say the tumor probability that we have to know tumor biology is the most important to predict patient survival. And second is the patient selection. Imagine that, for example, we only perform in the limited tumor in the healthy patient, and then your survival is getting better and better. So, and so lastly, surgical technique, unfortunately, is princess a weak power to affect the outcome. So we need to consider multiple factors when analyzing surgical outcome. The basic principle by Dr. Cardi says biology associated factor is the most important. For example, this factor in the high CEA level was a big bulky tumor mass or the progressive tumor in the short period, or the metastasis also simple and reliable factor. And selection is also important. We know that selection bias is an important factor to analyze the outcome. And surgical activity is very small. And I'm showing a typical example found in our previous publication. Here, this is a famous paper from the Professor Nagino over 10 years ago. He analyzes 574 patients with hierocholangiocarcinoma, and uh, he wanted to see the time trend of survival like this. But this is a R0, M0, and N0 subset. This subset is accounted for 42% of the whole patient, and he observes 20% survival gain at 5 years, probably due to the surgical innovation. But in one subset, this is a poor prognosis subset, no change, completely overlapping survival curve. This finding supports the Dr. KD's wisdom. The technique is prince and biology is king, like this. So our primary goal is to improve the whole patient cohort with cholangiocarcinoma, not only the resection cohort. We have to increase the survival of the non-resection cohort. So when we divide resection and non-resection, there was a very big difference between these two cohorts. You can see the survival curve here and check like this. The death after surgery is observed in the 3-time period. First is a surgical death. This is 3%. And early disease death. This means early death died from the early disease relapse. This is 15%. And usual disease, this is seeing additional 38%. So we need to think the following 5 points to improve outcome. First is expand your indication of resection to move the non-resection cohort to the resection cohort. And two is reduce 90-day mortality here. And three is reduce the chance of disease relapse like this, and prolong the survival in patients with recurrent tumor, because over half of the patients have the disease relapse after surgery, unfortunately. And if possible, revise the unresectable scenario of the patient, initially unresectable patient. So interestingly, the three, right, this three is associated chemotherapy associated factor. So we move to this is a common disease relapse rate after R0 resection. Unfortunately, over 50% of the had a disease relapse at 5 years. So most important is 10% disease relapse is observed after 5 years. And this is a nodal metastasis and venous invasion is a big two factors closely associated disease relapse. So this common relapse rate tells us adjuvant chemotherapy is a means to prevent post-operative survival. To my knowledge, to the best of knowledge, there are 6 RCTs on adjuvant chemotherapy against biliary tract cancers here. And the upper 4 is already completed and published in the major journal. And the lower 2 study is now ongoing. And I would like to introduce this BCAT study because of this study was conducted by our Nagoya team. So all the surgeons in Japan were waiting for the data opening, expecting the increasing overall survival by gemcitabine. But actually, you can see completely overlapping survival curve between the two. Red color is gemcitabine group and black color is surgery alone. So completely a total failure. This interesting finding supports another oncologic wisdom. It seems that the efficacy in the unresectable setting does not always work in the adjuvant setting. And you can see another study you can using gemcitabine and plus oxaliplatin, more stronger regimen than gem alone. But this study also is completely negative and overlapping survival curve. From these two studies, game-based chemotherapy seems less effective in the adjuvant settings. In contrast, fluorouracil had showed a good result, capecitabine and S1. Both is a similar, a little bit different, but similar fluorouracil agent. This is a positive finding. So first is a famous BILCAP study like this. Medical oncologists generally methods intend to treat analysis, namely as using all randomized patient analysis. So overall survival in the ITT setting is generally predefined as primary outcome measured in the protocol. But the BILCAP study has opened in Lancet in 2019 and hazard ratio is 0.81, non-significant in the ITT analysis, but it's 0.75. And the p-value is less than 0.05, excluding some patients because this is a per protocol setting analysis. Primary endpoint was not met in this scientifically. But capecitabine has been globally accepted as, considering the disease rarity in the West and fast efficacy in the protocol set analysis. And updated analysis outcomes was opened in 2022. This red color is a capecitabine, and this is a confidence interval, and this is blue color. You can see the narrow difference between the two grouping, and the hazard ratio 0.84 is larger than the previous studies. No less effective. And per protocol analysis, this is also pretty overlapped with this group. So nonetheless, capecitabine remains a sole standard of care in the world. But in Japan, capecitabine cannot be used for biliary tract cancer, so we need another study using S1, another fluorouracil. This is widely used in Japan for many cancers, but I know that in Thailand it's very difficult to use S1 for some, of course, in the biliary cancer or something, many cancers. This ASCOT study in Japan demonstrated a better survival in S1 group, 62% and 5 versus 51% at 3 years, but 10% difference at 3 years. For me, this is very good, but 10% gain at 3 years is seems smaller than I expected before. The rest subset analysis. So we see this subset analysis. Well, I'm very sorry about the very small character, but N1 positive margin, no, N1 node positive, and this is stage 3, 4, and R0. These patients as a good effect, show the good effect by S1. So the best candidate is R0. N0 is a very simple and good candidate for S1 adjuvant therapy. And R1 patient probably needs another adjuvant setting therapy. And we conducted S1 S1 trial for limited in the node positive patient series in 50 patients, and 50%. We observed that 50% at 3 years after half a year given S1 given. So how do you think about the 50% at 3 years for node positive disease? This is another graph previously showed in Professor Nagino, node positive subset, and move this graph here. You can see the very good improvement, 5 years, 50%. So about at least 20% gain in the node positive setting. So I recommend, I believe adjuvant chemotherapy should be given in the poor prognostic proportion, represented by node metastasis, bulky tumor, or poor differentiation tumor, or something like that was advanced staging. So I'm moving on the next topic, systematic chemotherapy, because of over half of the patient who has received surgery, unfortunately had the disease relapse. So we need to give this regimen to the patient. We have used the GEM and cisplatin therapy for over 10 years. But now not anymore. We use the GEM cis-based chemotherapy, but the triplet therapy is now available. And GC plus S1. This is very popular, limited in Japan because of the high response rate of over 40%. This is a very good response rate. CR plus PR mean 40%. But globally, Topaz 1 and Keynote regimen, or these are the very popular with response rate is about 30%. 30%. Then which do you choose among the three? Probably it depends largely on preference of the surgeon or the medical oncologist or institution. Probably it's okay because a direct comparison of these three regimens remains unclear. And this is one example of Topaz 1 regimen, GEM6, and durvalumab, ICI immuno checkpoint inhibitor regimen. This PR ratio is 7 PR means tumor size down over 30% is found in 27%. We can see the CR completely response means 100% necrosis is found in 2%. Surprising result. The CR is, but over half of the patients are stable, not changed. And surprisingly, this is a non-resection patient group, but has a 2-year 24% and 3-year 15%. Very good result. So we think about sorry. I think that this is I show in my previous personal opinion. The spectrum of cholangiocarcinoma is unresectable and resectable divided into two. But actually, this is not true. Practically, this is we have a gray zone between this border and marginally. How do you say this area margin? For example, this is a marginal resectable disease means seemingly resectable but surely poor prognostic disease, or hesitant to resection due to technical difficulty or high mortality risk. This is a very problematic area between the resectable and unresectable locally advanced disease. And now the policy for combination of the rejection and systemic chemotherapies remains controversial. I showed one example. This is advanced intrahepatic cholangiocarcinoma. You can see the big tumor here, and she has upper abdominal pain, very big pain, so indicating the abdominal wall invasion. And another, you can see the intrahepatic metastasis and IVC invasion and compression of the CVD. So we think this patient is a locally advanced disease, unresectable disease, and after histologic confirmation by liver biopsy, we initiated the GC plus the durvalumab therapy. After 2 months, after 3 cycles given, then you can see the PR finding, tumor shrinkage, extensive tumor shrinkage. So we press the instant here. You can see like this, no invasion. And IVC is free from tumor. Also, so we decide to resect. This is only one simple short clip of my video presentation. This is a 10 hours operation shortened in the 2 minutes. So it's not reality, show the reality. And I select the central hepatectomy in this patient because this is an intrahepatic cholangiocarcinoma, not hilar cholangiocarcinoma. And the main tumor location is the segment 4 G's. So remove segment 1, 4, 5, 8, and biliary extrahepatic biliary rejection. This hepatoduodenal or a little bit fibrotic indicates probably the previous tumor invasion. And 8, we can see the lymph node 8A swelling. Step-by-step manner, we isolate the major vessel. This is GDA, this is CHA, and lymphadenectomy is performed. And then portal vein is isolated like this. This is a right posterior, right anterior hepatic artery and divided. And next, this right anterior portal vein. It's right posterior portal vein is here and divided like this. And then we advance the dissection into the hepatic site. This is P4, medial segment portal vein, divide and free. Umbilical portion is freed from the higher plate. And review transaction is advanced along this line. Usual right trisectionectomy line. And divide left side violently. Frozen sections to this is middle hepatic vein. The caudate mobilization is mobilized from this surgical view. After cut view, you can see the completely mobilized caudate lobe. And then to the another side, the liver transaction. This is almost similar to the left trisectionectomy. The right hepatic vein is exposed in the upper part of the upper part, only upper part like this. And finally, the right posterior duct is divided. And the specimen is removed. This compression of the central hepatectomy with bile duct recession. You can see the two stamp here, left and posterior, and you can see the full vena cava like this. So this is histologic finding of the patient. You can see the tumor here, not directly invade the hepatic hilus, but very near. So when we preserve the hilar plate, then probably the tumor is completely exposed. The histology is shown here. This is the ICI. We use ICI, so extensive lymphatic infiltration is observed like this. The necrotic rate is 30%. And this is one example case of the conversion surgery from initially unresectable case. Because this is only we start this conversion resection program since 2023. So only the 13 patient. We have 30 patient, very limited experience. But you can see the procedure is a very extended approach. For example, this is a left trisectionectomy and a dual vascular resection. This is also the left trisectionectomy and right hepatic vein resection and reconstruction and IVC reconstruction, or like this. And the caution should be paid. Completely necrosis is found with 3 of the 13 patients. So this is limited, but I believe that the future we have to challenge this type of surgery along with the liver transplantation for the hierocholangiocarcinoma. So this is my summary about the chemotherapy for cholangiocarcinoma. First, adjuvant fluoropyrimidine after definitive resection is probably the gold standard. Capecitabine or S1 should be given. And the priority of the chemotherapy, adjuvant setting chemotherapy, is a high-risk subset represented by node positive. This is patient. This is a very simple indicator. And systemic triplet chemotherapy, GEM, CIS plus something, is very important in the future. And finally, ongoing conversion resection is now challenging in Japan, probably in the world. And thank you for attention. This is our member, not the criminals. And today, three guys visited this meeting. Thank you for attention.